Um, so it is my pleasure to introduce Dr. Konstantin, who is the Frederick P. Is it Suspan Professor of Obstetrics and Gynecology and Division Director of Maternal Fetal Medicine at The Ohio State University Wexner Medical Center. He graduated from the American University of Beirut, completed his residency in OB/GYN at the University of Cincinnati, and fellowship in maternal fetal medicine at the University of Texas Medical Branch. At Ohio State, he oversees the clinical research and administrative operations of the Division of Maternal Fetal Medicine. He is currently the principal investigator for OSU's participation in the NICHD Maternal Fetal Medicine Units Network and is also PI on numerous other federal and industry-sponsored projects. We are really excited to have you here today to talk about your ongoing research.
Thank you, Katie, and also want to thank Kara and the Preeclampsia Foundation for the invitation. I'm really honored to participate in this summit. I'm going to go ahead and share my slides. Okay, well, I'm not allowed to share my slides.
One sec.
Hi, Tom. How you doing? Thanks again for the invitation. I thought we can talk today about the Aspirin randomized comparative effectiveness trial that we're currently starting. And before we do this, just want to acknowledge the grant support for this study and other work in preeclampsia domain. I don't need to remind the audience, but this is placental-mediated adverse pregnancy outcomes as a group, including preeclampsia, preterm birth, growth restriction, fetal demise, complicate 1/4 to 1/3 of all pregnancies currently, and have been increasing in frequency and severity over the past decades. This comes along a parallel increase with other comorbidities, including hypertension, diabetes, obesity, cardiac diseases, etc. And all of these conditions combined are associated with really significant maternal and neonatal morbidities and mortality with very limited preventive strategies. Specifically for hypertensive disorders, again, I don't need to remind this group or the audience, you're all very familiar with these conditions. Currently, it's estimated that around 15% of pregnancies are affected by one form or another of these hypertensive disorders. And similar to the others, adverse pregnancy outcome, they still pose significant maternal neonatal morbidity and mortality, both on the short term as well long term for both mom and the baby. And they kind of the front face or the face of the racial and ethnic disparities that is affecting obstetrical care in the US, both as related to the frequency as well as severity of these disorders when it comes to Black patients versus white patients and others. In addition to this, hypertensive disorders put significant burden on the healthcare system with recent estimates of more than $2 billion cost in or healthcare costs in the first year alone after life for both mom and the baby after pregnancy complicated with preeclampsia. In face of all of this, the only therapeutic that is available currently or recommended for use is aspirin, which has been shown in studies to reduce risk of preeclampsia. And that's the one that's currently the only available recommended treatment for patients who are at risk of prevalent preeclampsia. And that evidence for the benefit of aspirin came from several studies, which we're not going to go over in this presentation because there's a lot of them. But just going to touch briefly on it. There were some together in several meta-analyses. This is one of my favorite one, which is called the Paris meta-analysis, published I think 10, 15, to 12 years ago in Lancet, and basically showed that antiplatelet agents, specifically aspirin, were effective for the reduction incidence of preeclampsia as well as extreme premature delivery by around 10, 15% or so. And this meta-analysis, among many other data and studies, led professional societies, United States Prevention Task Force, in their data as well as others, to recommend low-dose aspirin for the prevention of preeclampsia and hypertensive disorders. And currently, the United States Preventive Services Task Force recommend aspirin, and they list risk factors for people who are at risk to develop preeclampsia. And these risk factors were adopted by professional societies and currently are standard of care, and both combine into high risk factors and moderate risk factors. And I'm not going to go through them, but patients who have any of the high risk factors, such as history of preeclampsia, diabetes, hypertension, are recommended to use low dose aspirin, and those who have at least two moderate risk factors are also recommended to use low dose aspirin. However, despite of a lot of these data, and despite the tens of studies that looked at the benefit of aspirin in prevention of preeclampsia, there's still significant controversy related to the dosing of aspirin, the timing of initiation, the mechanism of action, the ideal population for which the medicine works the best. And that stemmed from several studies. More recently, the Aspirin study that was published from the Fetal Medicine Foundation, in which people who are at risk for developing early preeclampsia were randomized to placebo or 150 milligram of aspirin, found that using aspirin in this population led to a significant reduction in the incidence of preterm preeclampsia by almost 62%, which is significantly higher to what we've seen earlier on in the meta-analysis that reported around 10 to 15%. And I put the dose of aspirin here because the current aspirin available in the United States is 81 milligram. In Europe, Australia, and other countries, something goes 75 to 150 milligram. So there's a discrepancy in the dose of aspirin that are currently available. But at the same time, also the studies that were done regarding the doses of aspirin varied from 60 milligrams all the way to 150 milligram or 162 milligrams. In additional data, and showed this meta-analysis showed that as the dose of aspirin increases in these studies, then the benefit in the preeclampsia reduction increases. So as we go from 50, 100, 150 milligram, at least apparently from the combining all of these studies together, then the reduction of preeclampsia gets better and better and better. And not just only the dose that it seems to be effective or important, but also the timing of initiation, as shows in this meta-analysis, which showed that for aspirin to be effective, it has to be started before 60 weeks of gestation, compared to the forest plot in which there was no benefit seen if aspirin was started after 16 weeks of gestation. However, the story doesn't. It gets a little more complicated because there's additional data that shows, well, there's still benefit with aspirin even when used at lower doses, such as 75 milligram and 80 milligram, not just 100 or more. And also, a follow-up meta-analysis for the Paris meta-analysis published in 2017 showed that there's really no significant difference if aspirin is started before 16 weeks or after 16 weeks. And currently, the American College of OBGYN doesn't put a 16-week limit to start aspirin. And people can say, well, what's the confusion? All of these meta-analyses are using the same studies, but coming up with different conclusions. And that's true. And there's a lot of controversy, and there's a lot of ways to think about them. But one difference between these two is that one, the Paris meta-analysis is more like an individual data meta-analysis in which you actually look at individual people versus some of the other meta-analysis that look at aggregate data. And the other point I want to make that some of the studies that are focusing on less than 16 weeks or smaller in size compared to the one that is focusing more than 16 weeks, which always can lead to some bias in data. So with all of this, people in general are confused, including patients, healthcare providers, about what to do. We did a survey a few years ago for 100 OB/GYN providers in the US, asking them whether they recommend 162 milligram of aspirin for preeclampsia prevention. As I said earlier, the standard dose in the US is 81 milligram. That's the one you find in aspirin bottles. And people have started to give 2 tablets of aspirin. And we were surprised that 76% of the respondents said that yeah, at some point they may tell their patients to use 2 tablets of aspirin instead of one. And the reason for this varied, but included things related to the findings from the Aspirin trial that I showed earlier, in which 150 milligram of aspirin was beneficial. But also they think that the patients who are at higher risk of aspirin, whether they've had really multiple episodes of preeclampsia before or the preeclampsia was really severe and bad in the prior pregnancy, are benefit more from a higher dose of aspirin. However, there's no data to support any of this, which again led to a lot of confusion and led to experts' opinions basically pushing for the researchers to conduct the studies to evaluate whether a higher dose of aspirin is superior than the current standard of dose of aspirin to prevent preeclampsia, but also looking at the safety. We know that the higher the dose of any medication, then there's always sometimes increase in safety concerns. So all of these questions remain unanswered, and this was the impetus for us to submit a grant proposal to the Picori Foundation Patient-Centered Outcome Research Institute to compare 2 doses of aspirin for the prevention of hypertensive disorders in pregnancy. And that study, that proposal was funded and last March, and the study actually just started, and we'll tell you more about it. So the aspirin study, which is an abbreviation for the comparative effectiveness of 2 doses of aspirin, is called the aspirin study. It will be conducted at 11 clinical centers in the US called the Aspirin Consortium, and they are geographically distributed all the way from the West Coast to the East Coast, in the South and Northeast. They're structured in a way in which you'll have clinical coordinating centers run at the Ohio State and a data coordinating center run from Northwestern University, in addition to 11 clinical centers, a data safety monitoring board, an executive community advisory board, and 11 local community advisory board, each one at each of these sites that help to run and manage the study, as well as monitor its safety and monitor that we're actually engaging with the population we're trying to help in this study. The overall study protocol, just going to go briefly over it, but overall hypothesis or the overarching hypothesis is that we think that among at-risk individuals, 162 milligram of aspirin is superior to 81 milligram of aspirin. And also we wanted to determine whether there are multiple factors that are associated with adherence to aspirin therapy. As I mentioned, this will be a randomized, double-blind, pragmatic, comparative effectiveness trial. Double-blind means that neither the patient nor the provider nor the research team are actually aware of what the dose the individual is getting. We will be enrolling 10,742 individuals who are at risk for preeclampsia and eligible for aspirin based on the United States Preventive Services Task Force criteria. And they will be randomized to either 81 milligram of aspirin or 162 milligram per day. The 81 milligram group will take one pill of 1 tablet of aspirin plus a placebo-matched one, and then the 162 milligram will be taking 2 active tablets of aspirin. The medications appear identical, so it's in order to keep the blind for the study. These are the research questions we're trying to answer. Overall, the primary question is to determine if 162 milligram is superior to 81 milligram in preventing hypertensive disorders. And the secondary questions, whether the 162 milligram is superior than 81 in preventing or reducing the frequency of adverse maternal outcomes, such as gestational hypertension, preeclampsia, preterm preeclampsia, looking at various patient-reported outcomes. The third question, whether the 160 milligram is better in reducing the frequency of adverse neonatal outcomes. We'll talk about them. Also looking at aspirin-related safety outcomes between the different groups, and whether there are any facilitators or barriers associated with adherence to aspirin therapy. And last, to evaluate whether there's any evidence of heterogeneity of treatment effect that is affecting the effectiveness of aspirin. And again, the effectiveness is what's in general is whether it works or not in overall population. It could be affected by several factors. And within these subgroups that we're trying to determine whether there's any heterogeneity of treatment effect, whether aspirin, the benefit of aspirin differ between in individual groups. We're specifically looking at 6 subgroups. One, people who are self-reported Black versus white individual, and that is driven by the fact that, as I mentioned earlier, hypertensive disorders is more prevalent and more morbid among Black patients compared to white individuals. And the study is powered to detect at least 1.5 or to detect the difference in effectiveness between the groups. And with the goal is ultimately to find a dose of aspirin that helps reduce the incidence of hypertensive disorders to a level that is similar in white individuals. Also, we're looking at pre-pregnancy obesity status, mom's age at the time of delivery, whether the higher dose is more effective among those who have high risk factors such as diabetes, hypertension, twin gestation, prior preeclampsia, compared to those who have only moderate risk factors. We're looking at high versus low residual social vulnerability index, which is an index that assesses the built environment in individuals' community of residence, which again could be a surrogate for other social determinants of health, and sometimes can affect adherence to the medication and effectiveness of the medication. Also trying to determine whether there's any difference in effectiveness based on the gestational age of aspirin initiation. The inclusion criteria are pretty simple. If you have a live pregnancy before 16 weeks, the mom is more than 14 years of age and meet the criteria to use aspirin. We're excluding people who are allergic to aspirin or have hypersensitivity or aspirin is contraindicated. We're excluding pregnancies in which there's concern for major anomalies or genetic conditions, and a few other exclusion criteria. But trying to keep it very pragmatic to allow the broad range of patients to be included in this trial. After checking for eligibility, patients will be enrolled, consented and enrolled, and then randomized. They'll be given the entire supply of medications for the duration of the study. And I think this is something that's very important to touch on regarding the consenting process. I think Dr. Wright talked a lot about the involved patients in research, but consenting process is not just signing a form. It's an entire process for which it takes some effort. It takes actually some thought to have to put it together in order to inform the patient or the person specifically about the study that they're embarking on, the risks and benefit, make sure that all their questions they're being answered, making sure you give the patient enough time to actually think about it and read it carefully and have any questions that they may have. If someone doesn't speak English, then we usually use a medical interpreter to help to make sure that the individual is actually receiving the information accurately in their native language. Also, we use several techniques related to, teach back method and making sure the patient at the end of the day is understanding what they are consenting to. In addition to giving the patient a copy of their consent, we also give them a frequent information sheet. These are some of the frequently asked questions about aspirin use in pregnancy and specifically for the study, and with phone numbers and contact information if they have any questions as they participate in the study. And then after that, patients will be followed through regular visits almost every 6 weeks, which could be done virtually or in person, all the way until delivery, and then follow up postpartum to collect data and as well as conduct interviews. The primary outcome is hypertensive disorders, in general, combining both preeclampsia and gestational hypertension. We're also looking for several maternal important outcomes, including preterm preeclampsia, postpartum preeclampsia, We're looking at severe maternal morbidities, including admission to the intensive care unit, obstetrical complication, transfusion. We're also looking for a group of outcomes called core outcomes for preeclampsia, things related to mortality, development of eclampsia, stroke, blindness, retinal detachment, really the bad adverse outcomes that are associated with preeclampsia. And also specifically looking from a safety point of view about the bleeding complication of using aspirin in pregnancy, and dividing it between antepartum bleeding, abruption, development placental abruption, as well as postpartum hemorrhage. Neonatal outcomes are also varied and include preterm birth, birth weight, rate of growth restriction, also some core offspring neonatal outcomes such as stillbirth, SGA status, neonatal mortality, seizures, admission to the NICU, respiratory support, and several factors or several outcomes associated with prematurity in the listed here below. Also, we part of the study and part of the making sure that in addition to the medical outcomes that we're looking at, we're also looking for some patient-reported outcomes, evaluating both maternal health status, birth experience, maternal-infant bonding scales. And I have took a screenshot of them. We're not going to go over them, but they try to assess not just from a medical point of view, but about like patient's perception of patient, what are some of the outcomes that are really important for patients, and the satisfaction with the birthing process, as well as the perception of the bonding of the infant. And a lot of the adverse outcomes that happen in pregnancy can impact a lot of these important patient-reported outcomes. Also want to touch base about the adherence. There's some more data suggesting that adherence to medication actually affect the effectiveness of these medications. And specifically for aspirin, there are studies showed that if an adherence to aspirin less than 80% or 90% may actually negatively affect the ability of aspirin to prevent preeclampsia. And for this, we're trying to address or determine if there are factors that could be associated with adherence to aspirin. So a group of people from the study will undergo an interview 4 to 6 weeks in the postpartum period, in which the interviewer would talk to them about the perspective, about the knowledge and decision-making process from the study, experience in the study, healthcare experiences, and some of the factors they're looking at which could be affecting adherence to aspirin are patient-related factors such as age, race, parity, risk factors, therapy, at what time they were taking aspirin, did they take it with meals or not, and any additional medications, socioeconomic statuses, as well as healthcare systems. These are just examples, and there are many, many others. And for this, for this study, we actually developed the study website to make it easy for people to actually log in and figure out what this study is all about. And I'm just going to pause for a few seconds for people to, if they want to take use their camera to look at the QR code, and please take a look at the study. And if happy to receive any feedback about its content, about things that could be included. But in this study, we talked about it. We talk about what in the website. We talk about the study a little bit, what this study is all about, what I'm trying to achieve. We actually have a map with the site locations and the actual project, and there's an entire piece about educational material for people. But if you click on any of the site location, you'll actually be able to get a contact information about where the location of the site, who are the investigators at that site, the research coordinators, how to contact them. So for people who are interested in learning more about the study or potentially referring people to participate in the study. And I think there's something also that's very important for this study that I want to make sure we tackle really well. And we partner with the Center for Hopes at The Ohio State University, which is Center for Health Outcomes and Policy Evaluation Studies, and to develop what we call our engagement policy or engagement approach for this study. it's a busy slide, but if you look at the graph, the center of hopes is in the middle, um, and work closely with the executive committee who actually run the study on a day-to-day basis. But the study is developed in a way that you'll have an executive community advisory board, um, that include different stakeholders listed in the columns on the left, from patients, people with lived experiences, community groups, patient advisory groups, clinician researchers, health plans, payers, hospitals, hospital systems, training institutions, and all of them will serve on this executive community board. But we also make sure that each site develop their own local community advisory board that include, again, patients, healthcare providers, people or family members that help the site investigators to make sure that the study is addressing the need of the community where they live. And there's bi-direction flow information, which the question coming from the clinical sites, question coming from the local community advisory board, go all the way to the steering committee of the study, and vice versa. And we have people from the clinical advisory, from the local community advisory board, joining the executive committee, and then members of the executive community advisory board are also voting members in the steering committee to make sure that the voice of all participants actually are involved in the decision-making process for the study. And we find this to be, although we just started with the study, like I mentioned, we found this to be really helpful as a lot of groups, different community groups, help us actually redefine some of the outcomes, change some of the languages in the study material, and I think that's a good experience. And for this, I want to thank you all for allowing me to present at this meeting, and I'm super excited to take any questions. The only question was, how long has enrollment been open, and how long do you expect to be open for enrollment? So the grant, we received the grant in March, and we actually started enrollment in October, mid-October. Um, and we've actually, as of today, we have 48 patients enrolled out of the 10,742. So we still have 10,698 patients. The study is expected to keep enrolling all the way until, I think, February 2028. Right now, we have 4 sites that are activated. But the goal is to activate all the sites by the end of December or mid-January. And then we're also potentially adding 1 or 2 more sites, and that will be updated on the website.
So I think your both your primary outcome, but you have lots of secondary outcomes, which are, I think, also really interesting. And so you know that you'll be looking at not only sort of preeclampsia, but also gestational hypertension and postpartum preeclampsia. Is there sort of existing research sort of looking at those in terms of aspirin use as well? Obviously, yours is going to be, you know, quite a large study looking at those outcomes.
That's a great question. I think most of the older studies, focus primarily on preeclampsia. So, and many times, again, as you know, people have been researching aspirin for 34 years or so. So this definition of preeclampsia has changed. And with this large study, I think we're powered enough to look at some of these individual outcomes. Preeclampsia overall, preterm preeclampsia, because there's some suggestion that aspirin is predominantly effective in reducing preterm preeclampsia, not overall preeclampsia. And the individuals, once they enroll in the study, they take the medication all the way from randomization until delivery. And so the question is, what happens? Do you stopping the medication? Does it increase the rate of postpartum preeclampsia? So there's no data to suggest this, but I think it's a good opportunity for us to actually look at this one and make sure we'll be able to capture these data from this large cohort, and ultimately figure out also within not just a cohort, but also smaller individuals, whether the drug works preferentially better in one group versus another.
Majid, are you following for possible side effects? I mean, there's sort of been a slow churn about possible side effects of aspirin, depending on who you read. Are you guys collecting that information?
We're collecting a lot of maternal and neonatal fetal side effects in as during the conduct of the study. Things related to just a typical side effect from aspirin, dyspepsia, nausea, vomiting, headache, these kind of things, skin reactions, bleeding complications specifically. So within the data safety monitoring plan, there's specific focus on the bleeding complications for mom and baby, specifically the severe ones. We all the way until 6 weeks postpartum, but we don't have right now. We don't have any, or the current study does not include long-term follow-up. 2 years or so, especially for the child. I think there are some data from other study regarding long-term safety of aspirin in pregnancy, and that was reassuring. But we don't have it planned in this study as of right now. But during pregnancy, there'll be really granular data about the frequency of these side effects, time of onset, whether one dose is worse than others, and especially for bleeding, you're looking at antepartum bleeding, the spotting that people have when they start aspirin sometimes, heavier bleeding, placental abruption, coagulopathy, postpartum hemorrhage, and transfusion, all of these outcomes.
So some of the cardiology literature has discussions about aspirin non-responders. That's probably going to take a higher sample size, but any thoughts on that whole concept?
I mean, yeah, I kind of agree with the concept about non-responder. I don't think we don't have any biological samples collected in the study that kind of assess for the ability to determine the non-responsiveness or not. And so but that's something, at least for now, we're thinking about potentially submitting for additional funding to actually collect some biospecimen from some patient and maybe help us answer this question. Otherwise, I think it's going to be, we're planning the study as more pragmatic study, look at the effectiveness of aspirin in general, try to look at it in these different subgroups, but not specifically individual look at whether we can screen for non-responders using, whether prostacyclin assays or some other tests.
Thank you so much. I unfortunately had to step away to another meeting, but I'm looking forward to hearing all about it when I watch it a little bit later today. Were there any other questions? No, we had a couple in the chat, but it looks like we got to them. Fantastic. Thank you, Dr. Constant.
Thanks.
We are now headed to a lunch break. So we'll be back at 1 p.m. Eastern time from our break to hear from Jennifer Heiniger, our Director of Education here at Preeclampsia, about the changes in science and how that impacts patient care over time. So thank you all. I'll see you back at lunch.